Welcome to Patient Asthma Education for RT107, your clinical course. You can go over these slides just for your educational purposes and then taking the NBRC and just for normal practice. But you do have this essay that you have to write about how do you, as a respiratory therapist, educate your patient about their asthma. So we'll be discussing that here in this slide set. So the first thing is, why would you educate a patient? You need to remember that asthma education is essential to provide vital information to the patient because sometimes these patients have no idea what's wrong, what is asthma. So therefore, a patient with appropriate disease education can manage their symptoms better and prevent exacerbations. Therefore, it does save lives. Now, keep it simple when you're interacting with the general population. Patients don't tend to have healthcare background, and even if they did have health background, you want to be specific, you want to be accurate so that it's not misunderstood by your patient. And keeping simpler terms are the best. And if you are going to use a medical terminology, you must explain it to them. So say if you say bronchodilation, you should draw it for them, or you should tell them what it means. And then speak clearly. Slow your pace down if it's an elderly patient, or it's a child, or they're not cognitively understanding you. Look for verbal cues, their eyes moving around, or their body language changing, or them asking you questions. If they ask you questions, answer them appropriately, accurately, with evidence-based data. But if you don't know an answer, don't pretend you know it, refer them to their physician. I usually tend to say, that's an interesting question. Now, I'm not too sure. The best thing to get an answer for that is your physician. And then simply the patient will respect you for that. And you can start with the first thing is you need to ask the patient, do you know why you're in here? Sometimes they don't even know why they're in the hospital, especially in pediatrics. So if you have a teenager and it's okay with their parents that they know about their disease, uh, to be honest, there are patients that sometimes families have cultural backgrounds. They don't want to tell the patient what's wrong with them. In asthma, in most cases, they're so short of breath. It's easier said. So it's like, oh, you're short of breath. Let me give you some education. And you do need an order from your physician it'll say educate the patient for asthma. So anyhow, the first thing you would do it, you walk in, you have to build a rapport. You check their armband, ask them how they're doing, what your name is, what you're a respiratory therapist. Once you have built a rapport, then you can have an easier conversation. So if you see them in the morning for a treatment, don't be in a rush. In the afternoon or in the evening treatments is when you can start the education, because by then they know you. And start with, did the doctor or the nurse explain to you why you're admitted to the hospital? That's usually gets them going like, yeah, I know, I have asthma. Or they'll say, yeah, I'm really short of breath. They don't know what it's called. You have to be careful. You can't just say you have asthma when they don't. They have to have a diagnosis. Therefore, you need an order for asthma education from your physician, okay? Um, Now, what is asthma? They're going to ask you. Asthma is an inflammatory process. They might say, what is inflammatory? Then you can talk about WBCs, right? So inflammation in the lungs, and it's occurring. Explain to the patient that we breathe without any effort with normal lungs, because the bronchial passages that are depicted in the diagram here, they're open for air. You can draw this. I generally draw it on the whiteboard for my patients, or I get a clipboard, whatever it takes for me to make sure they understand the anatomy. And then I go into, well, when you're having an attack, it closes. There are a few reasons. One is swelling in the lining, excess mucus production, and of course the muscle tightness. And during the asthma attack, you can also explain that there are antigens such as grass. So say a patient is allergic to grass. You can give them examples. Say, you might not be allergic to grass. I don't know that, but I'm giving you an example that there's an antigen. You're allergic to maybe dust mites. Whatever you're allergic to will cause bronchoconstriction. Now, what is bronchoconstriction? Always elaborate to your patient what that means. And now, how do you reverse bronchoconstriction? That's the medication. And they might ask you, well, I don't know the medication, right? But before we get into medications, we can talk about what is a trigger, because the topic of trigger, they don't fully understand. If you mention grass, they say, no, nothing happens to me in grass. But there's something called the IgE test. How do we know what triggers my asthma is the question we're going to answer today. So you should be following up with your pulmonologist or see an allergist. Most of the time, allergists really manage this. So now this guy here, he's laying down, they've injected, or they sometimes put stickers of the antigen on the stick on the back for like an hour. And then you wait a few minutes, about 30 minutes, and you have to monitor them throughout so they don't have anaphylactic shock. And whatever area turns out red and has inflammation means they're allergic to that. So you could see here in 1, 2, 3, 4, it's all marked down. There's significant allergies in this patient, but in the end here, there's this H row, not that many allergies. But this person is allergic to a lot of things, so they might be triggering their asthma. This test can be done from kids to adults, okay? So anyhow, so most patients are referred to allergists. Just remember that. From a pulmonologist that can do this test safely. They usually have epinephrine on hand in case there's anaphylaxis, and they have airway management as well, RTs in the area. The patient's back is injected with the small common triggers. So these are common. They could be allergic to thousands of things, but they're trying to figure out what's the most common. And then once they have that specific answer to which antigen the patient's allergic to, that provides a lot of information for education. Basically, in modern medicine, we are saying, patient, you need to avoid these antigens in order to stop having asthma attacks. Okay, so what do these different triggers look like? Some people can be triggered by exercise, pollen, bugs in the home like dust mites. They're very, very little, 0.5 microgram. Chemicals, cold air, fungi, dust, smoke, strong odors, pollution, anger, stress, pets. Now, what I usually do is, so do you have pets at home? I ask the patient this. Or do you do gardening? Or what's your profession? Maybe they're a hairdresser, they're around a lot of chemicals. Then you have a better answer to say, okay, then you make a mental note. Then you always have to make sure that before you exit, you have a sense of what the patient situation is. So we've figured out we have triggers. We know how to interview the patient. But here are certain tips I've listed here for you that you can ask the patient. So read through these, like checking the armband, building a report. Do you smoke? Do you use recreational drugs? Or is anybody in your house doing that? Now, that's a sensitive question, so you have to be very tactful when you ask this. I generally ask about smoke once they really trust me, because my whole purpose as a respiratory therapist is to help my patient and not be judgmental in any way. And once they understand that in your body language and the way that you show the respect, they'll tell you, yeah, I smoke, or I've done this or that. That way you can get them relevant help. So anyhow, there's exercise, and then once you know that they smoke, or it's exercise, or maybe it's grass that triggers their asthma, how do you know if you're having an attack? Like, how do you feel? They'll tell you, oh, I feel tired, then I start wheezing, I can hear my wheezing. It's array of answers you'll get, okay? So then the next question, what do you do first? They might say, I take my temperature. I mean, things that could be instead of taking an inhaler or something, right? So we'll be covering that. Do you know how to avoid your triggers? So these are the things that can be part of your conversation along with doing your patient interview, okay? So if you don't read any of these items in the patient's chart, you can actually let your physician or know that, hey, by the way, the patient has been reluctant, but they wanted me to let you know that, yeah, they have smoked, or it's when they're anxious is when they get the asthma attack. And then we'll also talk about later how IgE therapy can be helpful, which I just mentioned above here, that some patients can take IgE therapy for a long time. And these Immunoglobulin therapies are basically, some patients are eligible to receive this to stop allergic reactions from occurring and causing asthma attack altogether. Isn't that wonderful? So IgE works when the patient receives injections every week or sometimes twice a week for a few years to up to like 5 years or even more when a small dose of antigen is provided to their body. So for example, say I am allergic to grass and I go to the allergy clinic every week and they give me injection for that grass. And it's very little. My body doesn't react to it, but my immune system sees it every single week. So we're training the immune system to not produce inflammation and send out eosinophils. Okay. Eventually, their immune system learns not to produce the allergic reaction, and they are basically cured of that disease. Okay. And then we have medications. It's essential that your patient understands there's rescue medication and there is maintenance, okay? You should always start by asking the patient if they know the names of their medications if during the attack or otherwise, like when you're managing them. If they're unable to tell you the name of the medications, this is an educational opportunity. So therefore, you start with rescue medications, always. Say, well, let me show you, what do you take? Does it look red? Is your inhaler red? Is it blue? Is it, if you don't know the name, do you have it in your purse, in your belongings? Did you bring it with you? Look at it and say, okay, you've been taking albuterol. So you know all these medications. So patient, I always encourage my patient to memorize their name, the albuterol's name. And I just make fun of it. I'm like, all better all. Can you memorize that for me? And most patients are able to. And then next time I visit them, I ask them, hey, what's your medication name? And then they know by then. This will ensure that they know what to ask for if they're running out of prescription and if they're having a conversation with the provider. Now, rescue medications are quick acting and they have short duration, right? They're SABAs. Albuterol, Ventolin, ProAir, Preventil are all SABA inhalers. They're all albuterols, just different brand names. And you need to also teach your patient about how to shake this particular MDI. Shake it for 10 seconds vigorously. Then the first pump is going to be prepping. If it's a brand new inhaler, they should prep it, which is priming it, right? And then they should take the inhalation. And you can always recommend having a spacer in between once you have seen how they're taking that breath. Now, rescue inhaler importance for your patient because these are SABAs. You don't have to tell the patient they're SABAs. Say these are faster, but they're going to help you breathe better. So they're fast and the cause of bronchodilation. Now, bronchodilation is a big word. Say they just open up your airways and then you're able to take in the air and breathe out. Just a reminder, during asthma attack, the air goes in, but coming out, it takes a long time. So there's a lot of obstruction. So educate your patient to make sure to only use albuterol when they are having an acute asthma attack. What is acute asthma attack to a clinician is not the same thing to your patient. They're not educated about, uh, wheezing, or sometimes they could feel the wheezing. They don't know how to define it. They don't even know if their heart rate is beating faster, about technically above 100. They just know it's faster. So for you and I, we would say in asthma attack, you have high heart rate, severe wheezing, or sometimes absence of wheezing, constant coughing, increased respiratory rate, chest tightness, tightened neck and chest muscles that show retractions, difficulty talking in phrases or full sentences, feelings of anxiety and panic, pale, sweaty face. These are symptoms for you and I. For you to teach your patient how they should know, it is a very subjective matter. So dangers of subjectivity are where it's actually known that people that feel like, oh, I don't feel short of breath, I'm okay, I'm short of breath a little bit, it's very subjective. You want to give it a number so that therefore we have the peak flows, right? It is known fact. So patients avoid going to emergency department and they can die from asthma. So, whenever you have an opportunity, you should provide the patient with full education, not only the peak flow meter, but we'll also go into asthma plans. So, in the peak flow meter, you need an order from the physician, and you just educate your patient based on their gender and height what is their best. Red is always go to emergency room. Yellow between red is also emergency room. Green, you don't have to go anywhere, you're just fine. But the border between the green here and the yellow, when they hit the yellow, they should be on alert. And they should definitely go to the physician or go to ER, okay? And then there's asthma action plans. These are quite famous these days. Sometimes RTs give it. Packard physicians used to give it so that they could learn what it is. It's basically teaching your patient about their triggers, how to manage their asthma, which medications to take, and how to find that subjectivity that we were talking about. Oh, I feel short of breath. That's very of a more of a symptom, right? Sign symptoms, right? That's more of a sign. We want to know that what is objectively their peak flow. So you can give them asthma plan. Now, here's the thing. Some hospitals don't have asthma plans. So it's a great opportunity for a respiratory therapist to push that hey, we're getting asthma patients, we should provide them with asthma plans. So after the rescue inhalers are done, we have maintenance medications. They do cause thrush. That's the tongue of a person with thrush. It's not very pleasant, and it can be taken care with methylene blue dye, but the whole point of this is you want to educate your patients as well as you yourself when you're giving them an inhaler medication such as inhaled corticosteroid, ICS. They should be rinsing their mouth. Now, they should gurgle and spit it out. Don't let them swallow it because it can coat the esophagus and thrush can develop in the esophagus. Okay? So when you're giving the inhaler, any type, whether it's a disc like the Advair or like a twisty inhaler, the Pulmicort, you should watch your patient how they take the medication. If they're not doing it correctly, always give them better tips to improve their inhalation from the device. Because if they're not taking it properly, they're not taking the medication. If they're not taking the medication, they will have asthma attacks. Okay? So sometimes students are wondering, how do I know which medication do I give at what stage? This is more advanced. You will have it eventually, I believe, in another lecture, but I wanted to give you an idea. In the same slide, if you look at the notes, there's actually a website. This is from a study. And it's basically first you always start with sawbus, albuterol, or sometimes Zopanex. Albuterol is fast acting, duration is 4 hours. It's going to open the airways, but you cannot take albuterol away. Okay, you have to leave it on for if it takes 12 hours, 24 hours, whatever it takes, because you don't want them to refractory and have bronchospasm. And then other things come in there, theophylline, LTRA, other inhaled corticosteroids. There are different steps. We won't spend a lot of time on here. I just wanted to provide you some resources. And by the way, just FYI, this is just for us, not for the patient, just in case RTs were wondering, right? So equipment, your patients will have a compressor like this, similar to this, and have their nebulizer. You will have to teach them about how to use it properly and how to clean that equipment. So I usually tend to start with, if they have an MDI, let's just start with MDI. How do you clean it? First of all, you just want to just wipe it, okay, with a mild soap type of, cloth. But if it's soiled, like something spilled in there and it's totally not working, you need to take this canister. You should know, remember, right? The canister sits in here. You should pull that out and only wash the plastic sleeve, okay? Because this actuator nozzle in here is very sensitive. So no needles in there, no poking in there with any brush, because it'll alter the diameter and your MMAD size may vary. So it won't be therapeutic aerosolization, okay? Then cleaning nebulizer, I always say to my patients that to use the clear vinegar with 3 parts water. So 1 part clear vinegar, 3 parts water, because it does not leave a residue. Soaps do. So first bowl, in one bowl you take the 1 part clear vinegar, 3 parts water. The second bowl you have sterilized water. Now you always want to teach your patients how to make sterile water if they are not able to just go to a store, and it's free. You boil water for 20 minutes with the lid on to kill any spores. You could tell your patients about what spores are, and then let it cool down and you can use it. And add and also make sure that they understand once they have all the setup done, you take your nebulizer parts, take them apart, put them in the vinegar water mixture, leave it in there for 5 minutes, rinse it in the sterile water, and let it air dry. Now here I've made a note, without pets or foot traffic is where they should be letting it air dry, because pets have dander, right? They have hair that can't be getting into this. Once it's air dried, they can put it in a box and keep it in a safe place. Okay. So, and also do not submerge the tubing in any liquid. They can wipe the outside of it, or if there's moisture in there, they can just run the compressor to aerate the excess moisture out of the tubing. Some compressors come with filters, and make sure to change the filter every year. The nebulizer companies that the ones that provide the nebs can give the filters, and sometimes they come in the box. Like 3 of them will come. And then we also want to actually really talk about dust mites. A lot of people don't know there are dust mites in beds. Um, if you have a new mattress, you probably won't have it. And if you have used from one person to another, like they're not being cleaned properly, there will be dust mites, and they're very, very little, 0.5 millimeters, right? Versus a bed bug. Um, Therefore, so a lot of asthmatics are allergic to dust mites. They should be washing their pillows every day or every other day with hot water, and they're specific asthma, hypoallergic pillows and beddings, and that's what you should be educating your patients with. Okay. And then what are other tips? So provide, when you're an RT, you should provide extra nebulizers to your patients who take more than one medication, so that they're not running out and they can wash it and they don't actually have infection from the nebulizer. That's why we wash it. Provide patients with educational material whenever available by the hospitals. Some hospitals have systems where they just print out asthma education little printout and go over it. You should provide those written notes. It's always helpful. And promote asthma education, and you should know the list of nearby asthma clinics or physician names or pulmonologist allergists, because these patients don't know what an allergist is or a pulmonologist is sometimes. So you should have their phone number, or like, hey, you know what? I know a really good physician. Here's their number. You can contact them. And the biggest thing is your advocates. RTs are advocates for their patients. So always provide the best care possible to your patients, because then they won't have any complaints. You'll feel happy. The patient will go home happy, and everything turns out just better. Okay, well, thank you so much, folks. I will post this soon for you, and you can write your assignments with this. Thank you.